I want you to move from overwhelmed by information to confident in what really matters. I want to help you move from being unsure towards direction and purpose in your healthcare. I want to introduce you to health experts. I want to let you in on tough conversations on women's health. I want to give you a place where you can lean in and learn how to take care of yourself. Let's transform your health. Let's get clear on your goals. This is Women's Health Unplugged. I'm your host, Dr. Jordan Robertson, Naturopathic Doctor. Welcome to Women's Health Unplugged. I'm Dr. Jordan Robertson. I'm a naturopathic doctor. Our focus for our conversations in the podcast mostly are around to help women feel more in control, more autonomous in their healthcare journey, to give you the kind of empowerment, the language, and the education that you need to actually be able to access the healthcare that you deserve. Today's conversation is going to be a good one. I have one of my friends and one of my highly esteemed colleagues, Dr. Alex Verge, joining me today. Hi, Alex.
Hi, Jordan. That's a nice introduction. Thanks so much.
Well, I could have said, this is one of the smartest women that I know, Dr. Alex Verge.
And then I'd have to say ditto, and then we'd go on and on and on.
Alex, one of the things that I love about you, and the reason why I wanted to have you on the podcast today, one, you're just one of the most sensible practitioners out there. And so the combination of just sensibility and heart disease, I feel like goes hand in hand, because this is exactly the kind of grounded, evidence-based, factual conversation that we need to have about this topic for women specifically. I love the information that you share. I love what it is that you do. And you've been working even with our clinicians inside the Confident Clinician on becoming better at cardiovascular health for their patients. So to me, I feel like this is just such a good marriage of the skills that you bring around research, your personality, which I just love, that practical, honest approach. I feel like this is just such an important conversation for our audience. Before we dive in, though, I always ask our guests how they got here, right? Heart disease is such a unique niche in our profession specifically, even though I feel like we all should be exceptional at this. It is kind of unique to just stand out and say, this is what I'm interested in. This is what I want to focus on. How did you get here?
Yeah, those are all great questions. And I really have enjoyed sharing the information that I've gathered over the years, both with clinicians and the general public, as well as my patients. It's funny, I had never thought about it that way in terms of the how kind of practical, sensible approach is really well suited to cardiovascular disease. But it's a kind of eye opener for you to say that, because it's so true. When we deal with cardiovascular disease, it takes such a long time for the progression of the condition. And it's the perfect example of something that you can't just power through and do something for 3 weeks and expect great results and a turnaround of symptoms. You may not have symptoms. You're looking for long-term improvement or long-term prevention of something that can take decades to progress in a certain way. You need things you can stick with. And having a sensible, practical approach, I think, is really key to finding those techniques that will be well suited to your life and your personality to be able to stick with, to see those goals achieved or work towards that. Anyway, that was, I love that. So thank you for pointing that out. That's a really nice thing for me. In terms of how I got here, I've been in practice for 20 years. And, back in the day, I think most naturopathic doctors were very, come one, come all, everyone comes through the door. You're sort of managing, maybe because you're the only naturopath in the area, or it was just the nature of the work at the time. And I think we all find that we really love certain areas more than others, or we attract certain people more than others, and develop our niche as time goes on, whether that was a conscious decision or otherwise. And certainly there's that component to it. I just kind of fell in love with the discussions around, kind of a funny way to put it, fell in love with the discussions around blood pressure and cardiovascular disease and cholesterol and so on. But I also do have a personal component that's added into that. And I think that's true of most health professionals across the board. We bring parts of ourselves to the table. And for cardiovascular disease, and in my situation, I have a pretty decent family history of heart disease. Lots of people in my paternal line who died early. And so it kind of weighs on you in a way. And so I know what it's like to think of a family history and feel what might be the impact on my own risk and my own health moving forward, even though there aren't any problems today. And as a complete aside, I also have like brutal white coat hypertension. And so, if anyone else experiences that, you know how that can be pretty off-putting sometimes when you're like, my blood pressure is fine most of the time. And then when I don't go and do a thing, and then it's really like, hey, did you know your blood pressure was high? So I can understand those conversations, and I love to bring that to the table with people.
I love that. And I do think that the practical approach is something that's so important. It's funny because and I didn't even think about it the way that you just phrased it, but you're right that like, this is not the same as other health conditions that maybe, and truly, like, I think a lot of health conditions could use this long game practical approach, right? If we're
For
being
sure.
honest.
Yeah.
But this is one of those things that it's not going to be this, like, the 3-week detox that you do that solves the problem. It is that long game conversation that we need to have with patients about behavior change, which I love. Like, I love that conversation. It just doesn't always fit with like that. Yeah, I feel like, I don't know, I feel like we have this dopamine seeking around healthcare often, where it's like, can you fix it? Can we fix it right now? And I think like the conversation around screening kind of lends into this a little bit. So we've talked about some screening tests on the podcast before, right? And that, screening is important if we can catch people at this sensitive time where it's going to make a big difference to their health. We don't just screen you all the time, right? We shouldn't look for that needle in a haystack with your health necessarily. But the conversation around screening and cardiovascular disease, we actually maybe need to have a slightly different angle where I don't know if we're screening enough, but I'd love for you to kind of contextualize that a little bit for our audience, specifically our female audience, and how you feel about cardiovascular screening and why this is something that all women, regardless of how old you are, maybe need to think about.
For sure. Yeah. And I will say that, of course, with cardiovascular disease, we're not screening for cardiovascular disease. We're screening for risk factors that increase the risk of developing cardiovascular disease overall. For the most part, there are exceptions to that rule, but usually when we're talking about screening in cardiovascular disease, we're talking about measuring your blood pressure or checking your cholesterol. And those are risk factors for the development of cardiovascular disease. And I think there's an important distinction there, because with risk factors are potential pieces. They're not absolutes, right? And so it increases your risk of developing something in the future. It doesn't automatically give you that thing in the future. And it means compared to the next person who doesn't have high blood pressure, doesn't have high cholesterol, your chances of having problems in the future are greater to some degree, to a small degree, to a great degree. It's all about identifying those things and kind of setting you up for success. And so in that vein, like, I think about risk factor management and identifying them and then kind of trying to change them if they're inappropriate, as setting you up for success. That's my like reframing of the scariness sometimes of being confronted with a high blood pressure measurement or a high cholesterol measurement. It's like, isn't that great that we know that now? Because these things take a long time to have a major impact in the progression. We have time and we can work on changing this, but we need to know it's a problem. So with screening, if we don't check until the age of 50 or 60, but this thing has been moving in a certain direction for the last 10, 15, 20 years, you've sort of missed this opportunity to make a really big difference. Different countries or different guidelines will suggest different screening schedules. And there's a lot of debate, which is the point of this question. There's a lot of debate as to the best way to do it. But there's a lot of talk about, quote, like knowing your numbers, which I think is really important and valuable. So even if you're 30, if you don't know what your blood pressure is, I encourage you to start go check it out. You don't have to go buy a machine necessarily, although I advocate for everyone to have a machine, but that's
like, wait a minute, I take that back, go buy a machine.
Yeah. But even, I mean, they're not always ideal, but they're still valuable getting it done at the pharmacy or at the grocery store or whatnot, just to have a sense instead of, not thinking it's ever going to be a problem, or, thinking it's going to be a problem in 10 years or in 15 years. It's good to know what those numbers are now. So if you're under 40, and bringing it back to your specific question about women, we're often told that women don't have to worry about heart disease. That's not true. What is true is that collectively, our heart disease risk is lower than men for longer. And so it's usually around menopause that starts to change. And so if we wait till that time to start to monitor, we have nothing to compare to, and we miss the opportunity to capture those people who are already experiencing changes. So really long story short, I'm really encouraging people to know their numbers, cholesterol and blood pressure in particular, before the age of 40. And then you've got something to compare to. You also, if something is already amiss, you get to be on top of that sooner rather than later. And for women in particular, that means you don't get surprised in and around menopause when you've been told everything is totally fine, and then go, what do you mean my blood pressure is elevated? Not knowing that the menopausal change can have an impact in that area. And then as a really quick segue, I don't do things quickly, I'm sorry. I will try a really quick segue to the fact that with pregnancy, complications in pregnancy can also increase these risks. So if you've got someone who's 30 and had gestational diabetes, that's something that will increase future risk. So for someone like that, it doesn't mean that heart disease is knocking on the door next year. That's not what I'm talking about. But compared to someone who didn't have gestational diabetes, there is an increased risk. So for that person to be monitoring blood sugar, monitoring blood pressure and cholesterol before the age of 40 makes a whole heck of a lot of sense.
Yeah, it's so interesting. Like, as you're talking, I'm having all of these thoughts and ideas about like where our like either belief systems can kind of lead us astray, where our general like, pushing things under the rug maybe lead us a little bit astray. So yeah, and I'm just going to ramble here for a second. Like, risk factors, unlike that like on off light switch, can make people like artificially comfortable with having mild to moderate risk factors, right? Because it's not like you test positive, right? And then we're like, we're sound the alarm. We're saying, your cholesterol is not great, or your blood pressure is not great. And what that means is it feels like there's more of this like interpretation of whether or not of how we feel about it, right? Like, what shade is my cholesterol? Not, is it black or is it white? And that in a sense can actually delay those important conversations around change or around support, because we kind of sort of can put up with or have mediocre results for decades before they really become a problem. I think what we fail to educate patients about is that the issue with cholesterol specifically is lifetime exposure. Not like you cross this special line and whoops, now we've got heart disease. It's your lifetime exposure. So the cholesterol in your 30s is making a difference, even if your numbers are actually okay.
Yeah. And that's a perfect point. And I've started talking about those like cholesterol exposure concepts as like cigarette pack years, because that's a more familiar term, right? It's like, usually smoking, if someone's smoking a cigarette today, they're not developing lung cancer tomorrow. That I'm going to shy away from that now, but with cholesterol, it's like, what's your totality of cholesterol years? And even those modestly elevated levels over a really long period of time, those add up and develop. The changes as a result are developing. And so, that not binary scenario of like, oh, it's high or it's fine. That's not what's happening. It's shades, as you said, of levels that are going to have an impact over time. And I will say it's one of the number one questions I get from patients that, well, I see my cholesterol, there's no range on my lab work here. is it okay or is it not okay? And the interpretation comes from everyone. The interpretation comes from patients, it comes from doctors. I mean, the same number, depending on who you see as a health professional, will be it's totally fine, or actually it's something that I'm really worried about, you need to go on medication, and everything in between. Talk about interpretation. How is anyone supposed to make any sense of that? It's almost unnecessarily complicated, but I understand why it's complicated, because it's a risk factor and not a disease.
And I think when patients have this value of staying medication free,
Mm-hmm.
then I think we can let our bias make some decisions about how good or bad we feel about our cholesterol. Like, well, I think we'll tolerate it being higher than maybe we should, because where it's kind of gray. And so we just like we tolerate it. And then when patients feel like they're being asked to use medication for their cholesterol, or their blood pressure, because blood pressure,
Mm-hmm.
even though blood pressure maybe has like slightly better clear-cut guidelines, there's still that, like, because we diagnose it over time, we want multiple readings, we've got lots of white coat,
Yeah.
it's shades. And so then when patients get presented with medication, they feel like almost like attacked, right,
Yeah.
by that
Yeah.
recommendation, because A, they didn't see it coming, they can't feel that and it's that clinician's interpretation of their totality of risk that made the decision,
Yeah.
right? Which
Yeah.
there's not that
It's
many
pretty.
things that are like that. Everything else is a bit more black and white, in my
Yeah.
opinion.
Yeah. It's why some of my visits take so long. Because we're going through those details, because it warrants time for people. People want to understand why someone is saying, well, it's complicated and this is what it means. And these are the numbers, and why someone might say it's too high and someone might say it's fine. And the bias is included into that. It's an involved conversation, which most people are really interested in, given the opportunity to discuss and understand. And the medication thing's a really good point. Like, if someone is medication averse, or for very good reason, I mean, no one wants to be recommending or taking medication in a case that doesn't warrant it, right? Um, but this idea that it's, oh, either everything's okay enough that you don't need medication, or it's bad enough that you need medication, and this sort of gap in between, it's one of the reasons I love the work we do, Jordan. Like, it's so great to be able to insert ourselves in that in between space and say, there's room, there's so much room to maneuver between, you absolutely would never need medication, and, oh, you need medication yesterday, right? Like, there's so much that can be done. It's great work.
Mm-hmm. And that conversation we're not having often, the like, what happens if you do nothing?
Mm-hmm.
Right. And I think that fits really beautifully with this topic, with heart disease, because patients don't realize that their health behaviors, their genetics, all of these things are on this trajectory. I am making a motion with my finger in my Zoom screen, which it's everything that's on a trajectory for me gets this finger swipe across my Zoom screen, like it's increasing over time. But we don't talk often enough about what happens if we do nothing. And I think especially for women, where their heart disease profile changes so much over those couple of decades, maybe between 30 and 50, or for 35 and 55, that conversation in there probably needs to account for the, like, if you do nothing then.
Mm-hmm.
But how do you approach that? Because there's not that many 35-year-olds that are like, please tell me my heart disease risk. And that's what we're trying to
Right.
change with this conversation.
Yeah, for sure. Because they have so many other things to worry about, typically, right? Like, especially, don't create a problem where there's no problem is often the way we think as human beings. Like, why go looking for trouble? But the way I'll often navigate, I start with even my intake, right? So if I'm working with someone on one-to-one, incorporating questions in my intake, so I can at the very least screen. So if I'm seeing someone who's 39 for, I don't know, IBS, I may already have an inkling that at least as a point of conversation, I could say, oh, I've noticed that you answered these questions in your intake around pregnancy complications or family history. And I just wanted to mention about, general cardiovascular risk, something maybe we could discuss at a later date, why I think it's important, and so on. other times people are coming in, and if they're really motivated, it's because they do have a significant family history, and they're like, everything seems to be fine, but I had a dad who had a heart attack at 50, or a mom who was had a stroke at 62, which, just as a really quick point, when we talk about family risk and when it's going to be indicative of something to pay much more attention to, is when like a first degree family member, a male, is having a heart attack or some sort of cardiovascular event under the age of 55, but for women it's under 65. So that's important to keep in mind, because sometimes say, oh, well, I have a family history of heart disease, but my mom was like 64, like she was older, so as if that's an expectation. But because of our delayed risk, anything under 65 is considered sort of premature, if you will. And again, that was a bit of an offshoot. But you're not wrong, that a 35-year-old isn't thinking about it. So I start in my screening in general, for whoever I'm seeing. And then I do try and add that into my sort of education pieces, that we're talking about these things, that the awareness of these additional risks at earlier times. But it's a tough road to hoe, as they say. Getting people who have lots of other things on their plate to start thinking about cardiovascular risk at the age of 35, when either they've never been checked for blood pressure or cholesterol, or if they've been checked, they've been told that it's not high enough to worry about.
Mm-hmm, mm-hmm. Which is interesting, because then this other thing I was just kind of pondering when you were talking initially was like, that those same people and the people that are listening to this podcast would maybe self-identify as someone who would want to take control of their health if they were given an opportunity, right? That's that person that if they struggle with some other thing going on in their health, they say, well, what can I do? Right? How can I change this? How can I avoid medication? How can I make a difference? But we're not giving those people that opportunity. If we wait until they're 56 and then their cholesterol's high, and then they're given 3 months to change their diet, they can't make a difference to their cholesterol. And then they feel like an utter failure for having to go on meds, right? When that person like identifies as someone who would have made a difference, like as soon as we say, do the fiber, do the things, they're like gung ho for those 3 months trying to make a difference. But the trajectory of change happened way before that blood test.
Yeah. And people will say, gosh, I wish I had known about this earlier. I would have made those changes. And it doesn't mean people are necessarily willing to revamp everything to within an inch of its life at the age of 35. But there are certain things that are much easier to do, and certain things that are like no biggie, right? You're like, oh, I could just do this instead of this. I'm trying to think of an example of that, but if only I had known to do that, then that would have been easy to incorporate and make it a habit, right? So maybe we'll use the fiber example. So if someone's doing overnight oats with protein powder because they're really focused on having protein in the morning because they've listened to your podcast and they know how important that is, to add a tablespoon or work up to a tablespoon of psyllium to enhance fiber intake, not only for gut health, but for cardiovascular health, that would be so easy to do. It would already be part of what's going on in their day to day. But if they don't know that that's a component that could be helpful, why would they bother? And you're right. We don't often give the opportunity for the discussion and then for these changes to occur at earlier times that will lead to improvements or prevent problems. Yeah.
Mm-hmm. And so, I mean, we keep alluding to kind of like that 40 to 50 decade, or I'm going to say like that premenopause to postmenopause. Some women, it's going to be a little earlier. And those are the women that are missed in early screening the most, right? It's like, oh, I had a hysterectomy at 43 and no one's bothered to check my cholesterol since then. And I meet them at 53, which makes my blood boil, but that's besides the point. But we're kind of talking about this like bit of a decade span from reproductive years to post-reproductive years as being this critical window of screening. And maybe we're going to even verge on early screening for those patients. Why does that happen? Like, why is there that sex difference with cholesterol? I feel like women need to understand this so that they can have that more empowered thoughts about their cholesterol versus just saying like, women don't get heart disease, you know?
Right.
Yeah.
Yeah. Yeah. And so, I mean, the short answer is that hormones impact cholesterol. I mean, that's the very short answer, to the degree where we will see changes in our cholesterol levels through the menstrual cycle, through the month, which is super interesting. Right. And so some resources, mostly in the research settings, they'll talk about, making sure that they're testing women at the same point in their cycles, because the variation in cholesterol levels in the follicular phase, right after your period versus just before your next period, are statistically significant enough that it could kind of screw up the data in that research setting. That's not likely meaningful in our sort of day-to-day clinical practice, but it just goes to show how hormones will have an impact on cholesterol. So when we start to see these hormones change perimenopausally and then through early and late postmenopause, and particularly the change to estrogen as it does its variations and then starts to come down, we will see changes to lipids or cholesterol. So we'll see an increase in the LDL, which has traditionally been called the bad cholesterol, although we're trying to get away from that terminology because it's more complex. And decrease in, again, what's been traditionally called the good cholesterol or the HDL. And both of those are generally considered negative shifts in terms of heart disease risk to cholesterol. That's the most kind of succinct, well, it's probably not the most succinct, but a good enough version of what happens. And it typically is going to happen in the biggest changes you'll see are in the year before the final period into the year after, when you haven't had a period for a year. That's when you're going to see those biggest changes. It's layering on top of the fact that we're all getting older at that point, right? And we see increases in cholesterol as we get older, regardless of anything else. So you're going to see this like incremental change to cholesterol every year and every decade as we get older. But during that period of time, you get to see this jump, which is going to be individual. Some people see a smaller jump, some people see a bigger jump. And if you've been told that your cholesterol is not great, but not bad, all of a sudden you go from, oh, don't worry about it because it's not that bad, to, oh, geez, really, you should be taking medication. And like you pointed out earlier, people will feel not only kind of shocked by that information because they've been told for so long it's not really an issue, but they'll feel like they did something wrong. And that's not what's happened. It's just this physiological change.
It definitely plays into that narrative of like, I feel like I'm falling apart, right? At that stage of life, because
Yeah.
there's so many other things that happen. And then people go for a screening test and they maybe don't know what, like they don't have an expectation that things are going to look worse than they did before. But it plays into that entire idea of like, my health is falling apart as
Yeah.
I go through menopause. And the other thing I think is kind of interesting about that, like there's so many things that are accelerated during that year before the final menstrual period. But I mean, we're truly trying to change the education for women. Women don't even know that they're like quasi-menopausal during that year because they're still bleeding.
Yeah.
Right? We haven't like done a great job at helping women understand that slow progression into menopause, that a lot of the changes that are happening happen before the last period, even though that is when we feel like we've crossed the finish line.
Yeah, especially in women who are slightly less symptomatic, right? So if you've been having pretty significant symptoms for the year or two before your last period, maybe it's a bit easier to understand other things are happening too. But if you've been not having that many symptoms and then you have your final period and then a year and then you get these screening tests done and everything's dramatically changed, you're like, where did that come from? I don't understand. But I just wanted to go back to your point about the sort of earlier screening in that context, especially, and how crazy it makes you when people are not being screened after hysterectomy or early menopause. And those are, because of the change in hormones, those are legitimately identified traditional risk factors for early screening. So if you became menopausal before the age of 40 because of premature ovarian issues or a hysterectomy, a complete hysterectomy, that absolutely not only does it dictate a conversation about hormone support, but it absolutely requires a baseline kind of check at that point, because you're going to start to see the changes to cholesterol and blood pressure. But also in the what we're going to call normal time, when perimenopause and menopause can happen, and after 40, the earlier you are in that area, so 40 to 45 in particular, considered early sort of menopause, that's also a risk in terms of these risk factors like the cholesterol and the blood pressure changing. And there was just a study that came out recently talking about hysterectomy and these things changing. And even women who just had a hysterectomy, but the ovaries were left, also, if that was done before the age of 50, seemed to have a slightly increased risk. It's not huge. It's less than those women who may have gone into menopause pre-40, but it's still there. So these conversations are going to affect and should be had with so many women. I mean, this is not a small percentage of the population. And it really is this continued missed opportunity.
Mm-hmm. Yeah, if we put all those women in the same bucket, right? Like gestational diabetes. I'm going to throw in patients who had difficulty conceiving because they're maybe at risk for premature ovarian failure, and we probably could catch them in their 40s with cardiovascular changes.
Yep.
Patients with PCOS, which I know we haven't even touched on, but that's a whole pool of women who have increased risk. Hysterectomy, premature ovarian failure, strong family history. So family member before, which we just said.
I could add preeclampsia, so some hypertension in pregnancy, and sometimes I'll look at pregnancy as like a natural stress test. So if things are going awry there from a cardiovascular point of view or a cardiometabolic point of view, that can highlight that future changes are more likely. Two of the areas that I would add, I'm segueing a little bit, but fall into the same category because they're more likely to happen in women, are certain types of autoimmune inflammatory conditions like lupus or rheumatoid arthritis, for example. The links between that type of inflammation and cardiovascular risk in the future. And then radiation to the chest. We think of all these women who had breast cancer with radiation, and depending on where that radiation was done and how close it was, if it was left-sided rather than right-sided, and just where the focus was, that can affect the heart. You pick your battles, right? Like that's the appropriate treatment at the time. But those are the sort of questions that are important to ask. Or if we're listening to this podcast and this is you, and this happened in your 20s or 30s, this is something that your healthcare provider who's looking at these screening tools in your 40s and 50s, it's important, if you can, to bring that up to them, because it means that you have this extra risk potential and you want to be more mindful of those potential changes. So yeah, it is a bit of a laundry list. And if like you said, you lump all these women together with one or multiple factors, that's like a lot of us.
A lot of women.
Yeah.
And it's a lot of women and again, with sort of harping on the screening piece, where lots of people skipped their physical exam in 2020, 2021, and I'm just nagging all of you to go in 2022. Lots of the screening guidelines include every 2 to 3 years, depending on what we perceived your risk to be. So that's even if we were right.
Right.
Like if we're right about your risk, then maybe you shouldn't or don't need to get your cholesterol screened all the time if everything is great. But if you fall in one of those categories, you should have been tested earlier and more often, and you probably didn't go in the last 3 years.
Yep.
So traversing that menopause transition in 2020, 21, 22, throw any of those risk factors in there, we're creating this slight storm where a huge percentage of women are missing an opportunity to make changes they would have made if we had taught them about it.
Yeah, that's a perfect way to bring that together for sure.
So, which is why we're so excited about it.
Yes.
This is how we're going to turn this topic sexy, Alex. I swear to God, next year we're going to make cardiovascular disease sexy. I promise.
I love it.
So what numbers? Like, I think that's one question I think that would be helpful here is like, when you say know your numbers, like, what does that mean? Like, what do they actually need to know?
Yeah. So the know your numbers concept is the starting point of that is let's find out if you don't know what your cholesterol is, you don't know what your blood pressure is because it has never been done, or it's been so long ago, it might as well have never been done. The first thing is, if you're in a situation right now that warrants more attention, you discover that, right? So if it's never been done and then all of a sudden the number that you discover is by all accounts too high, right? There may be interpretation, but at some point, no matter who the person doing the interpreting is, the number is too high. And there are people who are going to have their first measurement of cholesterol or their first attempt at measuring their blood pressure where that is the case. So that's the first component of know your numbers. It's to double check that you aren't in an already precarious situation so that work can be done. So that's the first component. And then the second component is something to compare to. So maybe your numbers are totally fine. And you're right, by what is totally fine, what is not totally fine. And as you said earlier about blood pressure, there's a little bit more clarity, although that changes from guideline to guideline as well. The stereotypical kind of 120/80 is still what's thrown around as like, if you're there, that's fine. Lower is probably better, provided that isn't too low to be causing, issues with dizziness and instability and fatigue and so on, but that's a different scenario. And then as we get above 120/80, the guidelines will say the higher is worse. When you start getting over 140/90, you're paying attention, but it's about monitoring and knowing what's affecting your blood pressure. So when someone says, oh, I'm always under 120/80, we're not going to worry about screening quite as often right now, unless, of course, you fall into some of those buckets. If you're somewhere between 120/80 and 140/90, and it's fluctuating, we try and get a better handle on why that might be, where's that coming from, what kind of triggers, what kind of scenarios are leading to those changes. There's time of day changes, it goes up after we eat, there's different things that we can identify, but we want to be able to figure out why it's happening and catch it before it starts moving continually in a certain direction. And then with cholesterol, it gets even trickier, right? Because traditionally it's, well, what's your risk? And if your risk is low, then we don't, within reason, care really how high it is. I disagree with that opinion. And that's why there's a larger conversation at hand. But I also don't think that every single person needs to be on medication. That's not where I'm going with that either. Often the way I'll describe contextualizing the numbers to start is looking at what everyone agrees is too high. So there's a condition called familial hypercholesterolemia. It's one of the most common genetic conditions in the world. Up to 90% of people who have it don't know they have it. And it leads to a singularly high cholesterol level. It needs to be screened for if your cholesterol, your LDL cholesterol, is above 4.9 or 5 and above. That's in Canada. So in the US, that would be 190 milligrams per deciliter. So 4.9 or 190 milligrams per deciliter. If your cholesterol is above that, you're at risk of potentially having familial hypercholesterolemia. So if you're below 4.9, then this is when the discussions start to happen about how high is too high. And there's a robust conversation that goes along with that. But I'm definitely paying attention for most people when we're creeping above 3. So that's jumping around a lot there, but if anyone's listening to this and they go and get their cholesterol done and it's 4.9 or above, that warrants digging deeper no matter what, basically. Yeah.
Do not pass go.
Do not pass go. Yeah. Yeah. And I'm not saying there can't be other reasons for that, right? If you've got an undiagnosed thyroid condition, there are other reasons why you can see elevations of that level. But that's the number where everyone is sitting up and taking notice. And I've seen people not sit up and take notice with that, right? Because I will just say that healthcare providers are juggling lots of things as well. And if they aren't particularly focused in this area and aren't familiar with the guidelines, that open to interpretation sometimes extends to not noticing when something should be flagged.
Supervised neglect. That's the term my husband and I came up with when we talk about this in medicine. We call it supervised neglect, meaning like the person has gone for the test and we're still, or we know that it's there, but we're neglecting to do anything about it. That's what we call it. Okay, I love that. Like, and so we're talking like mostly about like blood pressure. Again, blood pressure, we've got a little bit more, we're a bit more hardcore about how we feel about the numbers with
Mm-hmm.
that. I would say where the issue comes in with blood pressure is that we tend to blame it a lot on like circumstance, right? Like, oh, there was a traffic accident on the way here, and so my blood pressure is a little high, or I'm really stressed, or I didn't get a good sleep last night. And maybe all of those things are true, right? But that we can't always ascribe your circumstance to what's causing your blood pressure. And if we find one high reading, we really should be diligently observing your blood pressure so that we make sure that we are ascribing the cause to the effect.
Yeah. And I feel, I was like, oh, as you were saying that, I was like, and I just said, sometimes it goes up after you eat and so on. And that's the thing that happens, right? We do say, well, that's why it's high, which, as you rightly pointed out, can absolutely be the case. But other people can go through those same scenarios and not see that number go to that degree, right? And so I mentioned at the beginning that I have some pretty intense white coat hypertension. I'm not alone. It's a fairly common phenomenon. We used to think it was completely benign, like just like an unfortunate scenario that occurs. But because your blood pressure is okay the rest of the time, your blood pressure is okay. We're not worried about that. We do now actually have evidence to suggest that if your ability to, if you respond to those scenarios with elevations in blood pressure, that probably is happening on a regular basis, right? So yes, it may be worse in the context of like this anticipatory, like you're at the doctor's office, you're at the pharmacy and you're worried what your number is going to be and the number goes up, that white coat hypertension anticipation, if you will. But the fact is, those types of scenarios are happening in your day-to-day in other ways. And if your nervous system responds in that way, as an example, it's responding in that way in other circumstances. And we now believe that means that you are more likely to have a blood pressure condition in the future if you have white coat hypertension today. So again, that's not a guarantee. But how I take that, and I'm trying to live my truth here, when I tell people that identifying and managing risk factors is like trying to set you up for success. So with this information for myself, I try and be more aware of, okay, if these scenarios are going to jack my blood pressure, then how can I make a more concerted effort to manage my nervous system response in those scenarios? Because if this is my tendency, I need to make sure that I check my blood pressure more regularly as I get older and that I catch it before it moves in a certain direction, because it is more likely to do that than the next person who doesn't have white coat hypertension.
So like the way I'll put it, and it makes me laugh thinking about the human condition sometimes, honestly, like we just get in our own way. That like I think when we're looking at risk factors, it's kind of like we're trying to use lab work to as a crystal ball, right? It's like we fuzzily can see the future. It's probably going to get clearer over time if we keep going down this path, but we're kind of using it as a crystal ball. And we can like lean into that idea that we'd like to use lab work as a crystal ball, or like to use a sign for something so easily for some things. And then we're willing to like dismiss it for other things also very easily, right?
Yep.
Like if I said, oh, like I saw a blue jay and a cardinal together, and that's a sign I'm going to meet the person of my dreams the next time I go out, we are so willing to latch on to that. And then if we say, oh, your LDL is like at 3.7, like my crystal ball tells us we're heading towards heart disease, right? Patients will be like, nah.
I'm sure it'll be fine.
And so I think, and we talked about this a little bit before we hit record, right? About how sometimes this conversation around risk is not pretty, right?
Yeah.
Like it's not, we do want to, or we want longevity, but we also sometimes it's uncomfortable to look at our mortality and our longevity in a practical way, which again is why I like really admire and I'm deeply grateful for your approach with this, because it is this grounding conversation around like, if we want what we say we want, which is longevity, to live independently, to maybe rewrite the future of our genetics. If we can see a long line of people ahead of us that have struggled with heart disease, do we want that story to look different? We actually have to start writing it at chapter 3 and not like in the last chapter of the book. If we say we want what we want, part of that is accepting some responsibility for being screened and accepting some responsibility around the behavior change that's required for us to change the ending.
Yeah. Yeah. And I think the thing with risk is because it's a potential and not a thing. Like if you're told you have a condition, it's like, well, I have that thing. With risk, it feels like a flip of a coin, right? So if I don't do something, chances are it'll be like, there's a chance it's going to be totally fine. And if it's kind of a scary thing to consider, developing heart disease, especially if there has been a family member and you're like, I don't really want to think about it. There's a chance that I won't have that. Even if I don't do anything, then I'm just gonna, I don't know, not do anything, or it doesn't feel as definitive because we don't know for sure. But like you said, if we're really trying to stack the deck in our favor and we have a vision of what we want for the future, there's a path there. And I think there are lots of people who want to help you down that path and provide the information, and other changes need to be made. There's public health things that need to be looked at and industry things that need to be looked at. It's not all about the personal choice, but it starts with the personal choice because that's what we can control to the greatest degree.
Yeah, I love that. And I do think if the people that are listening think deeply about who they are and what they want, they actually are the person who wants to be screened, right? It's just maybe not crossed their mind how important it was. Or maybe we've just never made them feel like it was important, which is part of why I wanted to have this conversation. That idea of like knowing your numbers. Cholesterol is an incredibly inexpensive lab test if you even need to pay for it out of pocket. Like we're talking under $30, right?
Yeah.
To have and if we said like there's this $30 thing you could do that would really help us understand the future of your health, right? We'd all be for it. But I'm not sure we've ever helped women understand how important this conversation is and when it's becoming important, which is in and around that 40th birthday, right?
Yeah. Yeah. That's a good way to look at it. I mean, I don't think there's any benefit in waiting later than that. That's for sure.
Alex, what I would love if you could kind of share with our listeners as we wrap up the conversation today, like what's your lasting message for women, right? Like, what do you want them to take away from this conversation? What do you feel like is kind of the most important piece of advice or information that you want to leave our listeners with?
Yeah. I would say that in women, heart disease is certainly underdiagnosed, and even when it exists, it's undertreated. And I think I just wish women knew more about what those risks and about screening, and the fact that there are these specific things that we can experience through pregnancy and through menopause that change our risk. And most of us are willing to do something about it if only we knew about it. So getting the information out there that we are not safe from this, it's something that is just as important for us, if not more so in many ways. And we can take ownership of that and get information at an earlier time. So I guess I would say there's so much that can be done to mitigate those risks. I want to leave it on that happy note instead of it's a big deal, but it is a big deal, but there's so much that can be done to mitigate that risk. We just need to know it exists. So get out there, get the screening done, and get it done regularly, especially if you have those things that we talked about, because I really think that earlier screening, being aware of these risks, specifically the ones that are associated, particularly with women, and being able to advocate for monitoring those is going to save lives. I really do.
I agree. When I think about even if you think about the way that women traditionally consume healthcare, we're willing to go more often, right? We're willing to make change. We're willing to do hard things. You can't do all those things if you don't know there's something that
Exactly.
you're working towards, right? Which I think it's partly an education issue, right? It's not a compliance issue. It's not honestly just that they don't know. And our screening is not right now written in our favor. It's partly why I wanted us to have this conversation. So bust down those doctor doors and go ask for a call.
Yeah.
Alex, where can our audience find you?
So I'm on Facebook and Instagram, same handle, Alex Verge ND. I'm more active on Instagram these days, and most of my content is cardiovascular related, mostly informational. I mean, we have pretty different styles. I'm pretty serious and just get some nice information out there, and you just get great motivation and information in such a fun way. I'm a little more straight-laced, I guess. But Alex Verge ND, I'd love to see you guys there. Yeah.
Awesome. Thank you so much for sharing with the community. And we'll put some links to your stuff. I know that you have some great handouts and things for people to get a little bit more cardiovascular inclined with their knowledge. And so we'll share some of that stuff in the show notes too. You can link directly there through the podcasting platform that you're listing on. But yes, go follow Alex on Instagram. She just gives it to you straight, right? And so thank you so much for being here and for sharing with the community.
Oh, it's been such a pleasure, Jordan. This has been so fun. And obviously, I feel really strongly about this message and know that you do as well. And I'm so thrilled we've had it.
Awesome. Thank you.
I hope you enjoyed that episode of Women's Health Unplugged. My goal is to help you feel more confident about your health. Please remember that what we talked about today in the podcast does not constitute medical advice, nor was a doctor-patient relationship formed. If you have questions about your healthcare or about how today's topic pertains to you, please take it up with your family doctor, your specialist, or someone on your health team.